morning, friends. Today we're going to talk about aphakia and pseudophakia. First, we're going to talk about aphakia. We're going to study aphakia in these subtopics, which would be definition, causes, optics of aphakic eye, clinical features, and treatment of aphakia. So let's talk about the definition of aphakia. Aphakia literally means absence of crystalline lens from the eye. There won't be a lens present in the eye. However, from the optical point of view, it may be considered as a condition in which the lens is absent from the pupillary area. So what will be the causes of aphakia? So let's imagine. So what will be the causes of aphakia, or what will be the causes if there is a lens in the eye? So congenitally there may be the absence of lens, or surgically the lens are removed, which is known as surgical aphakia, or aphakia may occur due to the absorption of lens matter. Like the lens was there in the eye, but there would be the absorption of the lens matter, which leads to the absence of lens in the eye, or due to the trauma, or there would be the posterior dislocation of the lens, so that in the pupillary area we will see the black points. So what will be the optics of aphakic eye? There will be hypermetrophy of high degree, which means there would be good farsightedness, but the patient won't be able to see the near sight or near things. The total power of eye is reduced to plus 44 diopter, which is from plus 60 diopter. The anterior focal point becomes 23.2 mm in front of the cornea, where the normal value is 15.7 mm. The posterior focal point is about 31 mm behind the cornea, where the normal value is 24.4 mm behind the cornea. And accommodation of the eye is totally lost. So the patient may come to you with the complaints of defective vision, and the patient may come to you with the complaints of erythropsia or synopsia. Erythropsia means there would be all the things would be red tinted, and synopsia means the patient will complain that everything looks blue in color. When we're gonna examine the patient's eyes, we're gonna see the following signs. The anterior chamber would be deeper than the normal. The pupil gonna look jet black because there would be absence of the lens, so the pupil will be enhanced and it would look like a jet black. There will be a iridodonesis, where the iris looks like it's dancing because there won't be any support of the lens. If there is a surgical aphakia, we can see a limbal scar present, which indicates that the patient has underwent previous surgeries. And on retinoscopy and autorefractometry, we're gonna see the patient has hypermetropia. This is how a jet black pupil looks. So how you gonna treat a aphakic eye person? So as there won't be no lens, we can provide the patient with spectacles, or we can give him a contact lens, or we can put an intraocular lens to it, or refractive corneal surgeries can be done. Spectacles have been mostly commonly used nowadays. About plus 10 diopter with cylindrical lenses for surgically induced astigmatism are required to correct aphakia in previously emmetropic patient. An addition of plus 3 or plus 4 diopter is required for near vision to compensate the loss of accommodation. But the disadvantage of spectacles are there would be diplopia, which is double vision. Field of vision would be very limited, and there would be roving ring scotoma present. Roving ring scotoma is also known as jack-in-the-box phenomena, where the object seems to jump in and out of the field of view as it moves out of and into the ring scotoma. It is named as jack-in-the-box because you would have seen a jack in a box where a joker comes out of the box and it moves in and out, in and out, in and out. That's why it is known as jack-in-the-box phenomena. What if the patient doesn't want any spectacles? We can provide him with contact lenses. So here are the advantages and disadvantages of contact lens. Let's talk about the advantages of contact lens. There would be less magnification of the image, wide and better field of image can be seen, cosmetically more acceptable and better suited for uniocular aphakia. But the disadvantage of contact lens are they are more expensive compared to spectacles. It is very difficult to wear, and corneal complications may be associated with the contact lenses. We can use intraocular lens implantation. Primary IOL implantation is done during the cataract surgery, and secondary IOL implantation is done already in aphakic patient. So these are the various intraocular lens used, which is anterior chamber intraocular lens, Singh and Wurst's iris claw lens, posterior chamber intraocular lens, and posterior chamber intraocular lens with 4-loop type. Refractive corneal surgeries are keratophakia, where human donor cornea is used to produce or increase an anterior curvature of the recipient cornea. Or we can use epikeratophakia, where it is a refractive surgical procedure in which a lamella of a donor cornea is transplanted onto the anterior surface of the patient's cornea. Or we can use hypertrophic LASIK operation. Now coming to pseudophakia. What do you mean by pseudophakia? Pseudo means false, phakia means lens. So pseudophakia is nothing but it is a condition where a phakic eye is corrected with an intraocular lens implant. Refractive status of pseudophakic eye depends upon the power of IOL used. Emetropia is produced when the power of IOL implanted is exact. It is the most ideal situation. Such patient needs plus glasses for near vision only. Consecutive myopia occurs when IOL implanted overcorrects the refraction of the eye. It means that if there is an overcorrection of the IOL implanted, the patient may have myopia, for which he requires a glasses to correct the myopia for distance vision also, and may or may not need glasses for the near vision depending on the degree of myopia he has. The patient may also develop consecutive hypermetropia if the power of IOL implanted is underdeveloped or not overcorrected. Such patient require plus glasses for distance vision and additional glasses for near vision. So how you will get to know that the patient is pseudophakic or not? So anterior chamber will be slightly deeper than the normal, but not as deeper as seen in aphakic eye. The pupil color would be black but not jet black. The presence of IOL is conferred on a slit lamp examination after dilating the pupil. When you're gonna do a slit lamp examination, you wanna see the IOL present in the eye, and the surgical scar can be seen near the limbus where the surgery is used to put the IOL into the eye. So how you gonna treat or how you gonna manage a patient of pseudophakic eye which comes with the consecutive refractive error or pseudophakia with emetropia? So spectacles for the near vision alone is enough for pseudophakia with emetropia, or bifocal or progressive glasses for the both distance and near visions may be required in pseudophakia with consecutive refractive error. And what if the patient doesn't want these corrections? So we can go for LASIK or ASA, which stands for Advanced Surface Ablation, which can be treated moderate consecutive refractive error. Or we can go for intraocular lens exchange or piggyback IOL when the consecutive refractive error is large. Thank you guys. I hope you like this video. Do follow me for such more videos, and do hit the like button and do subscribe this channel. Thank you.